Hello, friends. So today I'll be giving this brief overview on this topic, not necessarily maybe very pertinent to ICU. Nevertheless, it could be extrapolated to our practices as well. So I was asked to given this talk in an emergency conference at Ramaya Hospital on 21st Feb. So just thought to review this and try to see how this could be extrapolated to our ICU practice. So the topic is push dose vasopressors in the emergency department. So I'm sure many of the anesthesiologists who may be listening to this, they're pretty adept to using this push dose in the operation theater settings. And of course, emergency physicians also tend to use this. So what do we mean by push dose vasopressors? So push dose, as the name sounds, or you can also call it as a bolus dose vasopressors, is given as the name sounds as a bolus to attain hemodynamic stability in someone who is in a crash situation or a very unstable situation as a rescue measure. So, and in anesthesia, I'm sure many of you, when you are inducing the patient with propofol and so on and so forth, they would have this transient hypotension, and one would be using a bolus dose of phenylephrine or ephedrine to get the blood pressure up. So that is what is called push dose of vasopressors. So it is a modality used for temporary hemodynamic support in shock situation or in a where there is an acute episode of hypotension for whatever reason, or it can be any type of shock which comes in a sort of a crash situation. You would use it to resume the hemodynamic and gain control over the blood pressure. And we need to understand that push dose vasopressors or bolus dose is only a bridge before a regular infusion of certain vasopressors is started in ICU setting or even in ER settings. Because if the blood pressure is not resumed and sustains, then you would obviously have to start an infusion. So it is a bridge. And it is also a bridge until an underlying etiology. See, in ICU setting, that's why the push dose is something which is a misnomer, because we tend to start infusion for most of the patients because we need to ascertain what is the underlying cause for the hypotension, and that needs to. So as a salvage measure or as a crisis control, we would use this bolus dose, after which an infusion has to be started and underlying cause has to be ascertained and treated accordingly. So that is the whole context of push dose. So when you talk about indications for generally, conventionally, the push dose or bolus dose vasopressors, the indications are generally in acute hypotension. Most of it would be in the anesthesia settings or during intubation, because during intubation, you would be giving induction dose of opioid, sedation, and muscle relaxants, and you will be taking off the sympathetic drive, and they can have acute hypotension. And I'm sure most listeners, when you're intubating, you would keep an adrenaline as a bolus, or you would keep a phenylephrine, so on and so forth. Generally, in ICU, we tend to keep adrenaline as a bolus. So that is something that you, in a typical situation where you would need push dose or a bolus dose vasopressor, or in septic shock, where there is an acute sort of a hypotension that sets in septic shock, or someone who comes into ER, or in anesthesia setting. And when you look into the body of evidence for push dose vasopressors, most evidence comes from the anesthesia settings. And that has been extrapolated to emergency and ICU. So that is what we need to keep in back of our mind. And even in any shock, septic shock, distributive shock, or cardiogenic shock, as an acute crisis control, so we may have to use this push dose or bolus dose vasopressors to gain control over the blood pressure. So these are the typical intuitive conditions where one would utilize push dose or bolus dose vasopressors. So now, what are the agents that could be used as a push dose or a bolus dose vasopressors? So in anesthesia setting, the commonest agents that tend to be used is phenylephrine. And adrenaline is something we tend to use more commonly in ICU setting and maybe in emergency setting. Noradrenaline is something that is being looked into as a good alternative as the push dose. Albeit, I should say, this is not commonly used as a first choice, but there is a evidence which is building in favor of noradrenaline when compared to phenylephrine or ephedrine. We'll talk about it with whatever studies that may be available. And even vasopressin also is something that can be used as a push dose. And I'm sure you know in cardiac arrest, vasopressin also is used as a bolus like adrenaline. So these are some of the common agents that are used. So phenylephrine is an alpha agonist and it increases the systemic vascular resistance. And phenylephrine is particularly useful when you have a patient with severe tachycardia because it can cause transient bradycardia. So adrenaline is a both alpha and beta agonist. But the advantage of adrenaline is it is a useful drug in cardiogenic shock because it can increase the cardiac output, that it increases the blood pressure, and it is useful in situations where there is a bradyarrhythmias, where there is bradycardia because adrenaline can cause severe tachycardia. So noradrenaline has predominantly alpha action and some beta action. And noradrenaline is the first drug of choice you would consider, especially in sepsis or septic shock patients. In ICU, we would tend to prefer more of noradrenaline as infusion. So you could consider bolus. I'll show you some of the studies where noradrenaline seems to be more favorable when compared to the other agents. We'll look into the evidence. So vasopressin is sometimes useful in refractory shock. So these are the four sort of commoner agents that you could possibly keep in mind, which are used as a push dose or bolus dose vasopressors. So when you look into the evidence, so there are a whole lot of evidence. As you see, there are 17 RCTs and there are 4 dose finding trials, 3 prospective studies and 3 literature reviews. And here you can see there are good body of evidence with regards to norepinephrine compared to phenylephrine and norepinephrine compared to epinephrine, so on and so forth. So we look into briefly what is the evidence that has built comparing one over another. So very briefly, we'll talk about the key articles about whether push dose vasopressors are helpful. So I've taken just the recent studies. So this is Patrick et al. Most of the studies I'm showing you are from USA. So this is done in emergency department, Patrick et al. It's a retrospective observational study where they use push dose vasopressors in hypotensive non-trauma patients in 42 patients where epinephrine adrenaline was used every 2 minutes, and they found that the systolic blood pressure, of course, all these studies, as you see, are sort of a observational studies, case series, so on and so forth. So, of course, there was a good increase from systolic blood pressure of 78 to 93, MAP increased from 58 to 69, and more than half of the patients needed more than 2 doses of push dose or bolus dose vasopressors. And adverse effect, as you see, with the use of epinephrine was seen only in 1 patient where they had a severe hypertension. And this was another study by Clifford et al. In 2021, again from the US group, done in emergency, where they did this in prospective cohort study in patients with hypotension due to drug overdose. So, and 55 patients were there. 12 patients got phenylephrine and 20 patients got norepinephrine. So the survival, this was just an observational study, cohort study, where they found survival was better in phenylephrine group, 11 out of 12, and where epinephrine was used, 4 out of 20 survived. So you could argue this is just a prospective cohort study. It's not a randomized. So maybe epinephrine patients were more sicker. That's why they had to use epinephrine, so on and so forth. So survival in this particular study appeared better in phenylephrine. So this is one case report where they showed the use of vasopressin again from the US group. So there they used vasopressin 1 unit and there was a significant improvement in blood pressure from 80 by 51 to 141 by 102, and this patient survived at the end of 30 days. So this was another study again from the US group where Guet et al. In 2019 where they used pre-hospital bolus dose or push dose vasopressors, retrospective study, and population was patients who had systolic blood pressure less than 70. They took 574 patients. Here they used epinephrine 0.1 milligram. And as you see, the survival in patients who had hypotension needing push dose was less because, of course, it indicated that these patients were much sicker. That's why the survival was less compared to the group which did not get push dose. It was 64.6 versus 82.8. And patients who were alive at 30 days also was less in patients who needed push dose vasopressors, which basically tells you that these patients were possibly sick and they needed push dose, and that's why they did not do well. That's all it tells you. Basically, survival was poorer in patients who got push dose as opposed to someone who did not need. So it's basically saying hypotensive patients died more as compared to someone who did not have it. But that's all it means. So you can't take a lot of lessons from these studies, but basically they said push dose was something that pre-hospital they had to administer and they had to compare the statistics. So this was another study again from US where they used pre-hospital retrospective observational study where they took patients with systolic blood pressure less than 90, MAP less than 65, around 52 patients. Here they used epinephrine, 10 to 20 microgram, and hypotension resolution happened in more than half of the patients with push dose vasopressors, PDPs, push dose pressors, and MAP improved by 13 millimeter mercury, and repeat dose was needed in 42 patients. So basically, all the studies tell you that one dose may not be enough. You need to have repetitive dose. So all these 5 studies that I showed tells us that push dose vasopressors are helpful in trying to gain control over the blood pressure, helps in improving the MAP, and we don't know whether it really translates into good survival. So that's what we could tend to make out. And survival in this particular study, as you see, was 28.9%, where they gave epinephrine as a push dose. So these are some of the studies to basically say about the evidence from all the observational studies with the utility of push dose vasopressors. And in this particular study, severe hypertension, where they said it's more than 180 millimeter, happened in around 1 patient. So severe hypertension did not appear to be a huge problem when push dose vasopressors were used. So this was another study, Rotando et al., again a retrospective observational study, 146 patients, where they used phenylephrine and ephedrine. And here they showed blood pressure improved nicely from 80 to 106, diastolic blood pressure improved, heart rate improved from 93 to 99, and adverse effects was found to be in 11.6, and drug errors also was found in 11.2%. So these were some of the 5-6 studies that have been done in last 3 to 4 years, showing the utility of push dose vasopressors. So now the question is, the question that we have is, how about norepinephrine? Now the argument is whether norepinephrine is better than, because all the studies you saw used phenylephrine and they used epinephrine. And so we need to see, and vasopressin you saw one study. So we need to see whether norepinephrine is a better choice, push dose norepinephrine. I think this may be of relevance to my intensive care friends because we use more norepinephrine. Again, all the studies came from pregnant ladies undergoing spinal anesthesia for LSCS. So the data comes from pregnancy patients undergoing LSCS. So there were 7 randomized controlled trials, including 626 patients comparing norepinephrine versus phenylephrine. And they found that with norepinephrine, your bradycardia was significantly less, and norepinephrine group needed fewer boluses, and cardiac output and stroke volume was higher in norepinephrine group, and safety concerns were nil when compared to phenylephrine group. So this again came predominantly from the patients undergoing LSCS needing spinal anesthesia. So there were 2 randomized controlled trials, 211 patients comparing norepinephrine with phenylephrine with ephedrine. So they came from China and US. Again, here they showed norepinephrine group had fewer bradycardia, MAP was higher. So basically, these studies tend to favor norepinephrine when compared to phenylephrine and ephedrine. So then we had this particular study which came from Lebanon where they looked into cardiac surgery patients, Baraka et al., where they compared norepinephrine versus phenylephrine with epinephrine, and they found all 3 were effective with regards to systemic vascular resistance, but the increase in MAP was better in norepinephrine. So again, all the studies tend to show signal favoring norepinephrine when compared to phenylephrine and epinephrine. And these were 3 randomized controlled trials of 276 patients comparing norepinephrine. So we saw norepinephrine compared with phenylephrine. We saw norepinephrine compared with phenylephrine and ephedrine and epinephrine. And now we have norepinephrine compared with ephedrine. This came from Egypt and Iran. So here even norepinephrine MAP was found to be superior, and tachycardia was less when compared to ephedrine. Norepinephrine had less tachycardia. Then compared with phenylephrine, norepinephrine had less of bradycardia. So it had a good sort of a positive effect or favorable effect. So now the question is, what is the push dose they used in all these studies? When you combine all these studies, the prophylactic push dose of norepinephrine they used was 10.85 micrograms, and rescue dose that was used was 12.3 micrograms was the rescue dose they used. And so the point of interest for intensivists is what is the right dose of push dose norepinephrine that we have to use. So the suggestion from all the studies is the typical dose we use is 4 milligram in 250 ml of saline. So if you mix 4 milligram in 250 ml, 1 ml of this fluid, if you draw in 10 ml, 1 ml is 16 micrograms. So the dose you can safely, that is suggested to be used is 4 to 16 micrograms. So you can use 0.5 to 1 ml as a push dose norepinephrine in ICU setting also. So maybe if at the end of this talk for intensivists, we are more familiar and commonly tend to use epinephrine. So henceforth, you can use push dose norepinephrine, do this dilution, 10 ml syringe you keep, 1 ml is 16 micrograms, half to 1 ml, you can use it as a rescue measure in acute hypotensive situations in ICU. So, and the effective. So now what is the whole point? Why should we use norepinephrine in ICU or in emergency? Because norepinephrine is the first line of vasopressors for all our ICU patients like sepsis. Even in undifferentiated shock, it's a first line vasopressor. Even in cardiogenic shock, norepinephrine is the first line of choice. Is there evidence? I'll just take you through certain evidence. The sensor trial that came in 2019 showed that early norepinephrine was found to have a better shock control. It improved both blood pressure and it improved cardiac output. So we have good evidence to suggest that norepinephrine is superior to other vasopressors in ICU setting. And evidence of norepinephrine superiority comes from this Martin et al. Study from the French group, where here they compared norepinephrine versus dopamine and epinephrine. And they showed that norepinephrine group had reduced hospital mortality when compared with dopamine and epinephrine. And there was reduced risk of tachyarrhythmias with norepinephrine. So these clearly show that in ICU setting, norepinephrine always has remained the first drug of choice. And even this study from Belgium by De Becker et al. Showed that norepinephrine, contrary to the initial thought that it will compromise splanchnic perfusion, it maintains better splanchnic perfusion. Norepinephrine is shown to have better splanchnic perfusion. And studies in the rats have shown that norepinephrine, in fact, preserves intestinal perfusion much better than other agents. And this was another study by Levy et al. From the France, where in cardiogenic shock, norepinephrine versus epinephrine was compared. And in cardiogenic shock, norepinephrine is shown to reduce the incidence of refractory shock, and it is shown to be superior. That's why even in cardiology settings, we clearly understand from the subgroup analysis of the SOAP study and from this particular Levy study that norepinephrine is a better choice as opposed to other agents, even in cardiogenic shock. So the conclusions is push dose and bolus dose vasopressors are the tools that we use for temporary hemodynamic support, but it should not replace definitive treatment of underlying etiology. Most important, careful dosing and patient selection is crucial to minimize adverse effects. And always remember, push dose or bolus dose vasopressors is only a bridge until an infusion is started or until the underlying cause is ascertained and underlying cause is treated. And push dose norepinephrine is evolving to be having a good evidence. And this is definitely something that we could consider even in our ICU setting. And most importantly, education and training have to be done to all our nursing staff and to our medical staff to avoid dosing errors and complications due to push dose, because medication errors seems to be a common problem when you're using push dose, and even extravasation can be a problem. So that's about it. So request all of you to submit your valuable work to Journal of Acute Care. So you can visit my website to rehear to this lecture. So thank you. Thank you.